Hi everyone, and welcome back to the journey. As you can see, today we're going to be talking about hepatic encephalopathy and coma. Alright, so another way for calling hepatic encephalopathy is pretty much your photosystemic encephalopathy, and pretty much what it is a life-threatening condition that you see with most people who have liver disease that progresses to liver failure. Alright, hepatic encephalopathy is also known as neuropsychotic manifestations, psychiatric manifestations, just because when I get to the signs and symptoms, you're going to see the symptoms that they present, which goes with neuropsychiatric. All right, and that also is in the word too, encephalopathy, right? Anything with encephalo, that's dealing with the brain, so that lets you know liver function that ultimately is going to affect the brain. All right, so if you break down the words, you can kind of find the meaning within it. Now, this is also associated with portal hypertension as well as shunting from the brain, shunting of the blood from the portal venous system into the systemic circulation. All right. Another thing that you have is it can be reversible. So if you fix the problem, which is the liver disease or liver function, it can help to improve or reverse the encephalopathy from even occurring. All right, so if you don't remember anything that I just said from there, remember ammonia. All right, there is a correlation with the ammonia. When there's high ammonia, you have a higher risk of having hepatic encephalopathy. Of course, this is with your patients who have liver disease or failure in liver function. So this is not just a normal person where it's like, oh, you know, but it can affect someone who does have high levels of ammonia. You will start to see this encephalopathy occur. But just keep in mind, this is for your liver failure type patients. Also, with ammonia, it is the major ecologic factor that plays a part within this development. So like I said, if you don't remember anything else, remember the ammonia. So an increase in your ammonia from your enzymatic or bacterial digestion of your dietary or your blood protein within your GI tract. All right. So of course, the obvious is, for us to increase our ammonia, you have your GI bleeding, right? Because we have our blood proteins within our GI tract causes increase in ammonia, so therefore GI bleeding, right? And also your esophageal varices. So you're probably saying, what are these words? What are you saying? Don't worry, I'll have a video for esophageal varices as well as your portal hypertension, okay? So stay tuned for that. Another thing is increase in your protein for your diet, right? If you're eating a lot of meat or just having a lot of protein shakes or just anything that has a lot of protein, you're at risk for having high ammonia levels, as well as your bacterial infections and uremia. Another thing that you have is in your state of being alkalosis or hypokalemia. Now, alkalosis is pretty much the pH level within the body. The body strives to be at a neutral level at all times, but in some cases, when a patient is sick or a person is sick, you may see them have more of an acidotic or alkalosis. Okay, so alkalosis is your base, acidotic is your acid. All right. So in your alkalosis and hypokalemia state, that helps to increase, right? So this is not helping. This is making it worse, right? These are factors that help to increase the ammonia that is going to be absorbed from the GI tract and from your renal tubular fluid, which you do not want. So in order to decrease our ammonia level, we want to decrease our protein intake in our diets, as well as maybe giving antibiotics, mainly particular your neomycin, to help decrease your intestinal bacteria. Now we have our clinical manifestations, also known as our signs and symptoms, which is also known as our nursing assessment. So we have our early stages. So with our early stages, you're going to see minor mental changes and motor disturbances. Now, with the motor disturbances, you're going to have a deep tendon reflex where it's going to be hyperactive. All right, so the reflexes are going to be, you know, like almost like jilting or so, right? Slightly confusion, and they may look unkept. Sleep during the day, insomnia during the night, right? They have a hard time sleeping. And then also emotional lability, right? So their emotions, their mood is one minute it's up, the next minute it's down. things like that. So if you see a person who comes in with liver function failure or liver disease, and all of a sudden they're changed from their baseline, they were able to tell you that, hey, I'm in a hospital, my name is so-and-so, today's date is, February 2018 or whatever the case may be, right? And then all of a sudden, they don't really know where they are. They're taking off, they're pulling off their gown, they're looking unkept, their hair, before this patient always wanted to take a bath, now they don't really care. Those are some signs, subtle signs that you should start picking up and, trying to see, hey, what's going on? Maybe they need a lab test, right? To see. So just always be on your guard and monitoring, looking at what their patient baseline is and what it is now, because the changes are very subtle, they can kind of slip through the cracks. Now in the late stage, what you're going to find is they're going to be difficult to awaken, and they're going to be completely disoriented. So they're not going to be able to tell you, where they are, what's going on, who they are in some cases, all right? Lapses into frank coma and seizures, all right? So this is where, definitely you want to be, looking out for that. When you try to arouse them, do the sternal rub, see if they wake up, look for any seizure activity, right? Definitely want to be able to, react quick and, do safety precautions, put the bed flat, turn them on their side, while they're in the seizure, documenting what you're seeing in the seizure. All right. Also, we have anastoresis, which is your liver flap. And with that, it's pretty much the flapping tremor of the hands. And what you're going to see is when you have your hand up, right? You want to tell the patient to put their hand up. You see it goes down and then it comes up real quick. All right. So if you tell them, put your hand up, and then all of a sudden it just kind of loses its function, but then it reacts quick. All right. So like that. All right. This is seen mainly in your stage 2. Now, your handwriting becomes more difficult to understand, and also you have constructional apraxia. Now with this is the inability to reproduce a simple figure. So they will draw different things, like you may draw a star and you may say, hey, go ahead and repeat that, and they're not able to. Or, you'll write certain, you'll draw a circle and they're not able to complete the circle, or a box, whatever that figure is, they're not able to complete that, all right? And then your reflexes eventually starts to disappear, and your extremities become or may become more flaccid, okay? Flaccid meaning like, limbless, pretty much lifeless, that you're not able to contract or do any of those things. So that's a very, very bad place that you do not want to be. We have one more clinical manifestation, which is your factor hepaticus, and what it is pretty much is a sweet, slightly fecal odor of the breath that is presumed from the intestines, all right? Now with that, some people have said that smells like fresh mowed grass, acetone, or old wine, all right? So just know your liver patients or so, especially if they have really bad liver failure and they're going to, go into this encephalopathy, definitely, that's one thing that you want to kind of pick up on. I know some of you guys are like, I don't want to smell that, but again, it does help because then you can kind of know off the bat, because, you may say, their breath wasn't smelling like this. They just finished brushing their teeth. Why is it smelling like this? So sometimes you catch some symptoms that the patient may not always presume classically, but, slightly stuff of the breath, being able to draw figures, things like that, all right? Now we're going to move on to your diagnostic testing. Now with that diagnostic testing, we have our EEG, which stands for electroencephalogram. Now you see how you have the word encephalo, right? Same thing, encephalopathy. We have encephalogram, so definitely we were checking functions with the brain. So sometimes if you just know the root word of something, you can kind of figure out what's going on, all right? So we're going to have a testing done on the brain. They may put leads all over the brain, different patches. And what you're going to see if a patient does have hepatic encephalopathy, you're going to see a slowing increase in your amplitude brain wave, and the characteristic is going to be a triphasic wave. So you have your 1, your 2, your 3, all right? That's how you're going to see those amplitudes increase with this type of patient. Now, the survival rate of patients who have cirrhosis and have the encephalopathy, right, you have a 40% rate after a year or at a year, okay? You also, patients should be referred for liver transplantation after initial episode, okay? So definitely want to kind of get them on that list. And then some other factors that can also help or play a part is your lab test. And your lab test, definitely you can see your ammonia levels, because you can see that kind of corresponds, as well as your liver test, so you have your AST and your ALT lab work that you can look at. They're elevated, you know, definitely this patient had liver function, liver failure. So now we're going to move on to the medical management, and with that, you want to eliminate the cause, right? So whatever is causing the liver failure or what's causing the encephalopathy, you want to fix and correct that. So if it is bleeding, you want to correct the bleeding. If the patient hemoglobin is too low and they need blood products, you definitely want to make sure you get a type and screen, and you also want to make sure you have doctor's orders for blood consent, for orders and for blood consent, as well as the blood itself. You know, you check it off with another nurse, or if you have facilities where you just only have to just scan it, you want to definitely go ahead and do that and give your blood product. Electrolytes. If electrolyte is the problem, right? Remember, we have a problem with hypokalemia. If that is the problem, you definitely want to have your potassium replacement. Also, another thing that can cause or go into the encephalopathy is your sedation, tranquilizers, analgesics, things like that. So if that is what's causing it, you're going to discontinue your sedation, your tranquilizers, and your analgesics, and also your azotemia. So now you can also use your ammonia lowering therapy. So if your ammonia is high and that's the thing that you're trying to bring down, so that way the body doesn't go into the encephalopathy, you can give lactulose, all right? So lactulose is going to help to decrease ammonia by excretion in the stool, okay? So this medication is going to make the patient poop, all right? So you want to see 2 to 3 stools a day. I know nurses, you're like, no, I don't want to, because, you know, if the patient's not able to function and clean themselves, you're going to be the one to have to do it. But again, look at it as a good cause. It's for the fact of them, you know, being better. So I know, just put a mask on and just go ahead and get right into it, because it does make you poop a lot. And if, I don't know, for some reason, it just, a whole bunch of stool comes out all at once, like a big clump, okay? So I think that's pretty much it for that, okay? All right, so with the lactulose, okay, you're going to monitor for watery, diarrhea, stool, because that can be an indicator of over-medication. So you definitely don't want them to get to a point where they have diarrhea, because again, diarrhea means that you're losing water. Water leads to dehydration, okay? So that goes into our signs of side effects, okay? So we have bloating and cramps for the first week, so you definitely want to tell the patient, hey, you know, it's okay if you feel bloated or if you have cramping, because that's part of the side effects. You also want to monitor for hypokalemia and dehydration. And other laxatives should not be given with the lactulose. Why? Because it affects the dosage of the lactulose that is going to be given, okay? So you definitely don't want any other laxative to be given. It can go through an NG tube as well as an enema if the patient is comatose or administration is contraindicated, okay? IV glucose is to minimize your protein breakdown. So again, remember, you definitely don't want your protein to break down, because when they break down and they're released into the bloodstream, right, increase in protein is what going to cause increase in ammonia. So you definitely want to give your glucose, right, so that way your cells can pull on the glucose, use the energy to do its function rather than getting it from the protein or breaking down the protein. Vitamins are used to correct any deficiencies, and your antibiotics, you have your Flagyl, you have rifaximin, and then also, like I said before, your neomycin. And last but not least, we have our nursing interventions. So first things first, you definitely want to check your neurostatus assessment, okay? You also want to monitor input and output, monitor your vital signs every 4 hours. Of course, if they're already in ICU at this point, then definitely vital signs every hour or every 30 minutes if there is changes, okay? With your vital signs, you definitely want to check for your respiratory assessment, because they are going to be at risk for respiratory failure based on the fact of neural status, the change of neural status. So nothing dealing with the respiratory given in like the lungs itself, but remember, within the brain, right, you have different areas like the brain stem and the pons and things like that, that helps to regulate your breathing and, you know, respirations and things like that. So if the brain is not functioning, that in turn affects the respiratory system that it's facilitating. Okay, so the brain is facilitating the respiratory system to do its function. Brain's not working, respiratory system may be at risk. Remember, that is your ABGs, airway, breathing, circulation. That is a very important thing you want to look out for. If I don't have a breathing patient, I have a what? Dead patient, which you do not want. So they may need possible intubation. All right, so just, you know, be aware and look at the breath sounds, hear the breath sound, look at how they're breathing, if it's labored, right? If it's shallow. Also, you want to look at potential sites of infections like your peritoneum and also your lungs. So if the patient's already intubated, you know, they're already at risk for VAP, which is ventilated acquired pneumonia. So definitely you want to provide oral care, oral suctioning, things like that to keep their mouth nice and clean. And to get all of that secretion or that gunk that's resting inside their lungs. Change them every now and then, you know, every 2 hours. Position them so those fluids can loosen up. Also, you want to check the ammonia level daily. Right, you want to see how effective is the lactulose working. You know, is it being effective? Do we need to increase? You know, where it was 30 ml lactulose, you know, twice a day. Do we need to put it to 3 times a day? You know, or do we have too much and the ammonia level is now low? You know, things like that. So definitely want to check the ammonia level. Your protein intake, mildly restricted in patients who has who have a comatose, and also who's resistant to the lactulose or antibiotics. So sometimes lactulose may not work for these patients, right? Sometimes the antibiotic may not work for these patients. So we have to come up with a second plan of what we're going to do. So definitely you want to control your protein, because your protein is what is enabling the ammonia level to increase. And if the lactulose and antibiotics is not working, then we may have to look at, okay, we can control what you put inside your body. So that may be the next step. Remember, you're going to be on short-term restriction of protein diet. So that may be around 0.8 to 1 gram per kilogram per day. I know it doesn't sound like much, but it's just for a short period of time. You want to avoid foods that are high in protein, like your meat and your eggs, right? Because, you know, you eat a whole thing of steak and you already passed the restricted level of your protein intake. So definitely you want to avoid those type of foods. Instead, it is good to have more of a vegetable-based protein. It works better for the body, and you're able to even take up to 120 grams a day. And this is when you're getting ready to transition to that long term. It is a lot better, okay, for you. Also, an increase in your protein is going to take place 10 grams at a time within 3 to 5 days, okay? So you don't just all of a sudden, all right, I went from short term where I was taking 0.8 to 1 to all of a sudden the next day I'm eating chicken for lunch and dinner, and then steak, and then, you know, definitely let's put this in increments, all right? So 10 grams, 3 to 5 days. If the mental status has improved. If it has not improved, that lets us know that this ammonia level may still be, you know, circulating within the system. We're definitely going to hold off on that. Gastric suctioning is a good thing because it helps to decrease the ammonia absorption from the GI tract. So if I can pull it out of you before your body can absorb it, that's a good thing, because then your body doesn't have to increase the ammonia level, all right? Another thing we have is your benzodiazepine. All right, it helps with the encephalopathy. It is also good for seizures. So at the end of the day, it's like a 2-for-1 combo. And You want to maintain a safe environment for your patients at all times, and this is any patient, but particularly these patients because they may be confused, disoriented, they may not know what room they're in, they may think that they're home, they're trying to get out of bed, so safety could be an issue for them, so try to maintain that as well. And rehab, if the patient recovers and they're able to, use their limbs, definitely want to give them rehab services and things of that nature. And last but not least, you have your teaching and your support group. So you definitely want to teach the patient everything that I just mentioned here. Teach them about the diets and different foods and things like that. Dietary can come on the team, and as well teach them foods that they should avoid, foods that they can't eat that doesn't have that much protein in them. And if the patient has acquired all of this thing from cirrhosis because of alcohol intake or things like that, most of the time liver function or problems come from patients who have alcohol abuse. So if that is the case, because it's not in all, but a good amount of them, but if that is the case, you may want to direct them to an AA meeting, okay? So if any of you guys have been to an AA meeting in your psychiatric rotation, I know when I was in school, we did it in our psychiatric rotation. It was a mandatory thing for us to go to an AA meeting or any of those anonymous meetings, whether it was a narcotic anonymous, sex addict anonymous, whatever it was. So I went to an AA meeting, very interesting, very like what you see on TV. Hi, my name is Bob and I'm an alcoholic and things like that. And pretty much in the beginning, you're going to go there and you're like, what? This is weird. But it's definitely good to see just because you can see what they go through on a day-to-day basis. It definitely made me understand their standpoint a lot better and know that what they're going through is a struggle and a disease in itself. So it's very enlightening, very good to go if you guys have to go to that. It's a good thing to go to just so you can get that insight. And then also if you ever have a patient who has to deal with it, you can let them know exactly, hey, what it's all about. Because some people may think it's weird, and it's not. It's the fact that, people every day who struggle with the addiction or desire to get alcohol come together and say, you know what, we're going to work as a team to make sure that we sustain ourselves from it. Okay? And they, they do prayers and they tell their stories and they uplift each other. So it's a very good thing to go to once you get into your psychiatric rotation. And that is pretty much it. If you like this video, go ahead and give it a thumbs up. If you have any questions or comments, please feel free to leave that in the comment sections below. And again, those of you guys who have given me such great feedback, I just want to say thank you so much. It is definitely encouraging to just keep on pushing and keep motivating you guys and keep putting out these videos so that way you guys can learn and have a better nursing school experience. And if you have not subscribed yet, what are you waiting for? Go ahead and click that subscribe button. If you want to follow me on Instagram, I'll also have that link below in the description box. And again, thanks for coming on this journey. I'll see you on the next one. Bye.